In this lecture slide, we are going to talk on the more common structural and motility disorders of the esophagus. Esophageal diseases presents with varied symptoms, and we have to be very definite in these symptoms so that we can interpret rightly what the patient really meant of their experiences. For example, the heartburn. It is the most common esophageal symptom. It is characterized by a discomfort or burning sensation behind the sternum that arises from the epigastrium and may radiate toward the neck, while regurgitation is the effortless return of food or fluid into the pharynx without nausea or retching. Chest pain is a common esophageal symptom with characteristic similar to cardiac pain, and sometimes making the distinction very difficult. Odynophagia is more on pain. It is caused by or exacerbated by swallowing. It is distinct from dysphagia. It is more common with pill or infectious esophagitis than reflux esophagitis. While dysphagia means more time and effort to move food or liquid from your mouth to the stomach, or somewhat a feeling of sticking or lodging in the chest. And lastly, the global sensation. It is the perception of lump or fullness in the throat that is felt even when the patient is not swallowing. We have different kinds of tests to evaluate the esophagus. While the more common test nowadays, we have the endoscopy. It is one of the most popular because of its simplicity and less invasiveness. It entails the use of a long tube with a camera at the tip of the scope. It is a test we can record and examine real-time the internal environment of the lumen of the esophagus and stomach. While radiography, this is more popular during the 1980s, wherein you instruct the patient to swallow a contrast material, which is a barium. And we can demonstrate the reflux of the contrast media with patients with hiatal hernia. We can also examine the mucosal granularity, erosions, ulcerations, and even strictures. While endoscopic ultrasound, it is a combination of an endoscope and ultrasound with a transducer at the end. The advantage of ultrasound, this test over the alternative radiologic imaging technique, is much greater resolution attributable to the proximity of the ultrasound transducer to the area being examined. Manometry or motility testing, it is a gadget that entails positioning of a pressure sensing catheter within the esophagus and then observing the contractility following a test swallow. And a reflux testing, this is a ambulatory 24-hour esophageal pH recording using either a wireless pH sensitive transmitter that is affixed to the esophageal mucosa. It is important to note in dysphagia that this will be experienced by the patient during swallowing if the internal diameter of the esophagus is narrowed to less than 13 millimeter or 1.3 centimeter. You have to note that the adult esophagus is about 26 centimeter in length and the internal dimensions of 2 centimeter by 3 centimeter. So more or less you can have a approximation of the size. We have the more common structural disorders of the esophagus. Hiatal hernia is a herniation of the viscera, most commonly the stomach, into the mediastinum through the esophageal hiatus of the diaphragm. A sliding hernia comprising at least 95% of the overall. It occurs as a result of the weakening of the phrenoesophageal ligament attaching the gastroesophageal junction to the diaphragm. While the rings and webs, the origin is unknown, they are seen in about 10 to 15% of the general population and are usually asymptomatic. When the lumen diameter is less than 13 mm, distal rings are usually associated with episodic food dysphagia and are called Schatzky ring. And the diverticula, they are categorized by location, with the most common being epiphrenic, hypopharyngeal, or the Zenkers, and the mid-esophageal. They are the result from increased intraluminal pressure associated with distal obstruction, and most of them, small diverticula, are usually asymptomatic. We have three major entities of esophageal motility disorders, and they are achalasia, diffuse esophageal spasm, and gastroesophageal reflux disease, wherein they represent neuromuscular dysfunction. In achalasia, there is a loss of ganglion cells within the esophageal mesenteric plexus. Well, the incidence is about 1 is to 100,000 and found in the age between 25 and 60. The functionally inhibitory neurons mediate deglutitive lower esophageal sphincter relaxation and the sequential propagation of peristalsis. Their absence leads to impaired deglutitive lower esophageal sphincter relaxation and absent peristalsis. The ultimate cause of ganglion cell degeneration in achalasia is an autoimmune process attributable to a latent infection with human herpes simplex virus 1. A long-standing achalasia, there will be a progressive dilatation and sigmoid deformity of the esophagus with the hypertrophy of the lower esophageal sphincter. The clinical manifestation may include dysphagia, regurgitation, chest pain, and weight loss. And in the advanced achalasia are at risk for bronchitis, pneumonia, lung abscess from a chronic regurgitation, and aspiration. Achalasia is diagnosed by barium swallow or esophageal manometry. Endoscopy has a minor role other than to exclude the presence of pseudoachalasia, such as in patients with distal tumors of the esophagus. CT scan or endoscopic ultrasonography may be of value, especially when the clinical suspicion for pseudoachalasia is high and endoscopy is non-diagnostic. This is the X-ray appearance of a patient who ingested a barium meal for the demonstration of achalasia. As you will see, there is a dilated esophagus here with a poor emptying and a beak-like appearance there at the tip. The diagnostic criteria for achalasia with esophageal manometry are impaired LES relaxation and absent peristalsis. And this is the most sensitive diagnostic test. In patients with untreated achalasia, they are predisposed for development of esophagitis and eventually squamous cell carcinoma of the esophagus. There is no known way of preventing or reversing achalasia. The therapy is directed at reducing the LES pressure so that gravity and esophageal pressurization promote esophageal emptying. LES pressure can be reduced by pharmacologic therapy, forceful dilatation, or surgical myotomy. Pharmacologic treatment, usually they are ineffective and used only for temporary therapies. Nitrates or calcium channel blockers are administered before eating, advising caution because of their effects on blood pressure. We can also use botulinum toxin injected into the LES under endoscopic guidance. Also, sildenafil or alternative phosphodiesterase inhibitors effectively decrease LES pressure. Most common surgical procedures for achalasia are laparoscopic or Heller myotomy. They are usually performed in conjunction with anti-reflux procedure, which is the partial fundoplication. It has a good to excellent result in up to 100% of cases. Thank you.